Good afternoon, everybody, and you're very welcome to today's webinar, brought to you by the HSE on FASD. The audience is building nicely as we've just gone live, so you're all very welcome. My name is Leo Colgan, I'm from IMS, and we're hosting today's event on behalf of the HSE. So a little bit of housekeeping before we start. Below, you will see at the bottom of your screen the Q&A feature. So please feel free to click on the Q&A and ask questions throughout the event, and we will endeavour to answer as many of those questions live. And we have left some time at the end as well for some Q&A, some live Q&A. We'll also run a couple of polls during the event. So I'm going to launch the first poll here, and if you could give us an idea of, have you visited the website askaboutalcohol.ie/pregnancy for information about pregnancy and alcohol? And I can see you all voting busily away there. So while you're voting for that, I'm going to hand you over to today's host, Professor Joe Barry. Joe, can I invite you up on screen, please?
Thank you, Leo. And good afternoon, everybody. And we're delighted to see such a large attendance. I think people are still joining. This is a very important event, Fetal Alcohol Spectrum Disorder Awareness Day. It's a big issue in most countries, and ours in particular. And I'm delighted that we've such a great panel of speakers who are going to address you today. You can see the timetable is laid out there, that I'll only speak for about 2 or 3 minutes now, and then I'll be handing over to Dr. Mary O'Mahony from Cork, and then Mary will hand over to Geraldine Hanley, and then we have 2 speakers from Scotland, Dr. Sarah Brown and Dr. Jennifer Shields, who will give a joint presentation. And thank you, Jennifer and Sarah, for helping us out on this venture. After Jennifer and Sarah's presentation, we'll take some questions for about 10 minutes just on their presentation, and then we'll open up. We'll bring in the whole panel, which is the 4 speakers, together with Noelle Yunkin and Caroline Jordan, whose details are there on the table. So we hope it goes very, very well. We hope that you'll get a chance to get your questions answered. We'll try and get as many questions in as possible, and it is planned that the Q&A will give us a half an hour for Q&A at the end, so there should be ample time. We could even have some live questions. So you get your questions in advance, and we'll make note. And obviously, we'll endeavour to answer as many as possible and then spread that.
Joe, if you just unmute there.
Sorry, you can mute me. We will also be recording this event today, and so that's just to be aware of that yourself. And obviously, when we'll now, I think, ready to move on to the first principal speaker, who is Dr. Mary O'Mahony. Mary is a specialist in public health medicine in Cork, HSE South, and is a clinical lead in public health for fetal alcohol spectrum disorder and its allied problems. Thank you.
Mary, if you could just unmute, please.
Hello, yes, I'm unmuted.
Loud and clear, Mary.
Okay, I'll just share screen. Have I my screen up there correctly or not?
Not yet, Mary. So
Not
if you'd
yet,
like to
okay.
click share screen.
Right. Have I my screen up now?
That's perfect, Mary.
Okay, thanks. Thank you, Joe. And I'd like to start with an acknowledgement. Internationally and here in Ireland as well, its foster parents and adoptive parents have led the way in raising awareness of FASD and supporting research into fetal alcohol spectrum disorders. But we need to move now towards a more population-based approach. Birth mothers and their children are the greater constituent group, and along with foster parents and adoptive parents, they need support and care. Conflicting messages are a problem, and we need a consistent message for all women that no amount of alcohol at any stage of pregnancy is safe for your baby. We need to mainstream fetal alcohol spectrum disorders. We need to get rid of the stigma and recognise it as a disability. This slide shows the global prevalence of fetal alcohol spectrum disorder among children and youth in the general population in 2012, and shows that Ireland has a high rate of fetal alcohol spectrum disorders. In fact, the evidence in Ireland, in a study of 187 countries, Ireland featured among the 5 countries with the highest prevalence of fetal alcohol spectrum disorder. And the evidence indicates that in Ireland, 4 in 5 of first pregnancies are exposed to alcohol, and nearly 1 in 2 are exposed at high risk levels. 2 in 5 pregnancies are unplanned, increasing the chance they will be exposed to alcohol. Pregnant women do not consistently receive timely maternity care for alcohol problems. Health professionals do not consistently provide information on the risks of drinking during pregnancy, and we have no routine screening for alcohol during pregnancy. Most clinicians lack the capability to diagnose fetal alcohol spectrum disorder, so it largely remains undiagnosed. And families of people with fetal alcohol spectrum disorder struggle to access appropriate support and report a lack of understanding from services, professionals, and even other family members. In New Zealand, where they've looked at it, they find that 50% of children in state care have fetal alcohol spectrum disorder. Now, it took 20 years of sustained advocacy to get fetal alcohol spectrum disorder included in standard coding and classification of diseases. And it's now included in DSM-5 as neurodevelopmental disorder, prenatal alcohol exposure. It's an alcohol-induced brain damage which is permanent, although there may be some remediation possible due to brain elasticity. And as highlighted in the earlier slide, children with fetal alcohol spectrum disorder are very overrepresented in state care, as are adults with FASD in correctional facilities. Fetal alcohol spectrum disorder contributes to the well-known transgenerational cycle of addiction, as those with FASD are at increased risk of addiction to alcohol themselves. In addition to the personal cost, there's a significant economic impact, so it also makes business sense to prevent fetal alcohol spectrum disorders occurring. For the person with FASD, it may be associated with physical, mental, educational, social, and behavioural difficulties. So the next 2 slides will try to look at the nature and the extent of the problem in Ireland. And looking first at the public health risk assessment, what population are most at risk? And the evidence would indicate that it is women who earn more than 35,000 per annum are the group of the population who are most at risk of having a child with fetal alcohol spectrum disorder, because they have enough disposable income that alcohol is always available in the home. And the next group at risk will be students and those from lower socioeconomic group, because they have a greater tendency to binge drink. The risk is very high. It only takes 67 women to drink during pregnancy for a child to be born with fetal alcohol syndrome, which is the more severe end of the spectrum. And only 13 women to drink during pregnancy for a child to be born with non-fetal alcohol spectrum disorder. But there are effective interventions that can help to reduce this risk. Screening and brief intervention for alcohol in adults is of proven effectiveness in reducing alcohol intake. And parent-child assistance programs for those who are at higher risk with maybe problematic drinking have been shown in North America to have good outcomes. Looking at gross indicator data of neurodevelopmental disorder in Ireland, there are 3 sources that I found. So the HSE's annual report for 2018 provided the numbers of referrals of adults to adult mental health and of children to child and adolescent mental health services. And those could be used to derive rates. And basically what this showed is that the rate of referral of children to child and adolescent mental health services is almost double the rate of referral of adults to adult mental health. And that's a worrying trend. The National Disability Authority profiled just less than 1,500 school leavers in 2016 who were seeking rehabilitation training or a day service. And I was able to review the details on the 286 from Cork and Kerry CH04. And I was surprised to find that it showed that 1/5 had no intellectual disability. Now, a very small proportion of those would have had physical and sensory disability, but that would have been very much the minority. And more than half, 56%, had no borderline or mild intellectual disability. Now, traditionally, people with mild intellectual disability really only ran into difficulty during their educational years. And once their education was completed, they would go on to get a job and have a full participation in life, independent participation. The National Council for Special Education did a report on special need assistance in school in 2018. And it showed that 3.5% of all students require special need assistance. There are many factors which influence the FASD risk, and the outcome of pregnancy varies. There is a genetic component to the risk. Also, nutritional status, access to prenatal care and intervention, access to contraception, child welfare policies, all can impact on risk. Also, life is difficult. And for women who continue to drink during pregnancy, there can be a reason for that. For those who may be pregnant and have been drinking, it's never too late to cut out alcohol during pregnancy. The brain continues to develop throughout the whole of pregnancy. So abstaining from alcohol for the remainder of pregnancy has benefit. We need community solidarity and a cross-societal approach if we want to reduce the incidence of fetal alcohol spectrum disorder. Internationally, there has been no reduction in prenatal alcohol use over the past 20 years. Indeed, the reverse is the case. Population alcohol per capita dictates the percentage of hazardous and dependent drinkers in the population. In Ireland, it's the societal norm to drink, including during pregnancy. It's not a woman's problem. 74% of alcohol is drank by men. It's an alcohol problem. It's a hidden harm of our alcohol consumption at population level. This shows our current poster and leaflet with our very clear, unambiguous message that no amount of alcohol at any stage of pregnancy is safe for your baby. And this message needs to be given consistently from our trusted sources, from the GP, the consultant obstetrician, the midwife, from all government-supported initiatives such as our drug and alcohol task forces. And I want you to know that the HSE has a very clear policy on public health information initiatives related to alcohol and does not support industry-sponsored initiatives. And this needs to be supported across government. The Department of Education needs to stop school use of alcohol industry-supplied materials. And we all need to support and designate the Department of Health through the HSE as the provider of the message and the message materials. So for prevention of FASD in Ireland, we need leadership and governance, we need health education, we need preventive services, and we need enabling policy and legislation. So we have the HSE Health and Wellbeing Alcohol National Priority Programme, and last week we held the first meeting of the Fetal Alcohol Spectrum Disorder Expert Advisory Group. The askaboutalcohol.ie/pregnancy HSE page is the main source of HSE information on alcohol. And we are also input into the school curriculum. We have the Know the Score modules for the senior cycle, social and personal health education, and we're also inputting into the junior cycle, SPHE. Screening and brief intervention for alcohol in pregnancy is needed, but before we can introduce it, we need to have adequate services for women, and we really need to have cross-societal support. The Public Health Alcohol Act in 2018, it needs to be implemented urgently and in full, particularly the provisions that allow for the pregnancy warning on alcoholic drink and to introduce the minimum unit price. Parent-child assistance programs, I suppose they're further down the line, and they will need cross-department like TUSLA and HSE support. Last October, there was an FASD conference facilitated by the Child and Adolescent Mental Health Service took place in Dublin. And at the end, there was a discussion group, and the priority need that was identified by those present at the end were the consistent message that no amount of alcohol at any stage of pregnancy is safe for your baby. We need services to diagnose FASD with brain assessments so that we can determine the child's strengths as well as the child's deficits. And support and training is needed for carers, including frontline workers, for their healing role. So I'll just finish up with this last slide. And the picture on the left shows the prominent conspicuous warning, which has now been implemented in New Zealand and Australia. It's a global first. On the right, you see the industry preferred label. And our own Alcohol Action Ireland, working with their NGO colleagues in Australia and New Zealand, helped to bring about this groundbreaking labelling initiative on alcohol in pregnancy warning. Thank you.
We're going to hand over now to Geraldine Hanley. Geraldine, if you could start your video and unmute.
I've shared the screen there now.
Yeah, that's fine, Geraldine. And if you just press from beginning over in the left-hand side.
Hi, my name is Geraldine Hanley, and I'm going to present a practice initiative change or practice change initiative that happened at Letterkenny University Hospital in 2014, and this was a prescription for a healthy pregnancy was the name of the initiative. This was a multidisciplinary, multi-agency group that was set up to address maternal alcohol consumption in pregnancy. The partnerships were between Maternity Services, Letterkenny, and specifically the Antenatal Clinic, and the Health Promotion Services, the Alcohol Forum, and Donegal Education and Training Board. It was decided to pilot the project, and prior to that we had a review of literature or evidence base, project descriptor, ethical approval was received, and a resource pack known as the toolkit was developed. A subgroup were active in developing the toolkit. We also had a staff training and masterclass in alcohol and pregnancy for CPT. The practical side of it, Audit C screening, was integrated into the booking antenatal clinic in Letterkenny University Hospital. As it was a pilot, it was piloted in one consultant clinic, and an evaluation did take place, both quantitative and qualitative, and a report was produced at the end. The project descriptor, one from the Scottish document, Integrated Care Pathways, would describe the project as local multidisciplinary, multi-agency response to maternal alcohol consumption, thereby providing pregnant women with information on the risks associated with use. Also, early assessment of alcohol-related problems in pregnancy, appropriate advice on use in pregnancy, and treatment and care options. Ascertaining the true prevalence and extent of alcohol consumption in pregnancy, as we know, is difficult to ascertain because of underreporting and a lack of understanding of what constitutes a standard drink, and therefore what constitutes low to moderate use. And this was addressed in page 18 of the toolkit. Health promotion advice. In antenatal settings, there is a responsibility to provide ongoing advice and support to expectant mums, including information of the risks of alcohol consumption during pregnancy that is up to date, consistent, and evidence-based. How we went about it, the audit screening was implemented into the booking clinic to address maternal alcohol consumption in order to identify the alcohol use among pregnant women along the continuum from alcohol use to dependency. An adapted SARE model was used within the antenatal setting, and then onward referral or appropriate referral. Provision of printed information and screening to first-time mums happened at 12 weeks and extended up to 20 weeks to include those who would be booking late at antenatal clinic. Follow-up at the 28-week antenatal appointment was regarding impact of intervention. The cohort that we targeted was based on previous 12-month period figures for booking clinics. So one booking clinic per week was chosen with 10 potential booking participants. So the cohort targeted was approximately 240 people. The toolkit developed contained a prescription for healthy pregnancy, midwife's handbook in relation to the SARE model, and this was used for the midwives who had the screening and brief intervention training. There was also the alcohol audit C tool, the alcohol prescription for a healthy pregnancy, and we also liaised with our Scottish counterparts to adapt the alcohol and pregnancy leaflet for use during the project. An evaluation report was completed. Quantitative measures identified the number of screenings completed and the outcome. The qualitative measures incorporated were the mother's experience, information and advice that they received at 12 weeks, follow-up at 12 weeks on the benefits and impact of same. We also evaluated the consultant and the midwife's experience of the training, the delivery in practice, and of the toolkit. The midwife's experience of the project overall was very positive, and they would have found that the multidisciplinary, multi-agency involvement was most helpful. Because of the multidisciplinary, multi-agency involvement, the process had very clear guidance from the beginning of the project. The training, overall the midwives found the information and training as an effective intervention for alcohol use within the antenatal setting. Training provided the midwives with practical tools to enhance the engagement with these pregnant women. The overall experience was positive. They felt the practice helped raise awareness with pregnant women on the harmful effects of alcohol on the unborn child. The practice also resulted in earlier intervention and appropriate referral. The stages of critical development chart was highlighted as a very useful tool when discussing the impact of alcohol in pregnancy. Midwives requested that this tool be used as a poster within the maternity setting. Scoring of the Audit C was thought to be slightly confusing for midwives, and it was requested that it would be amended based on feedback before rollout at the next hospital-wide level. This was the critical periods in human development chart that we used. Challenges for midwives. The process did involve extra time between the midwife and the pregnant woman during the booking process. This created somewhat of a challenge for us during busy antenatal clinics where we had confined space and a lot of attendees. However, midwives did feel that the benefits of the project outweighed the extra time spent delivering in practice. Further training has been requested by the midwives in the areas of maternal alcohol consumption, and this since has taken place. The toolkit provided a very reliable source of appropriate evidence-based materials for all health professionals involved. It incorporated the SIR model of care. The toolkit included the midwife's handbook on how to implement the same in practice, which was an invaluable resource for midwives. The leaflet was practical and useful, and the midwives requested that this leaflet would be produced as a standard resource. Key points on patient engagement. There was a high rate of return on the 12-week self-reporting questionnaire. The 28-week feedback questionnaire had a low response rate, but the response was overwhelmingly positive about the inclusion of information on maternal alcohol consumption within the maternity setting. Verbal feedback to the midwives was overwhelmingly positive. Consumer feedback on the leaflet was really positive, and for a lot of the pregnant women, they reported that they didn't realize the dangers to the baby from drinking until they had been involved in this process. The prescription tool was not considered to be either useful or very practical, either by the midwives or by the women. Our current status at the moment for our pregnant ladies in Letterkenny, overall, this initiative was deemed a great success in imparting key messages to women on maternal alcohol consumption. Consumer, midwife and consultant feedback confirmed that this was a very worthwhile initiative. Phase 2 rollout was planned but didn't progress. However, the maternity unit has since committed to the MEC process, and all midwives have received the MEC training with the rollout to commence in October 20. Sorry. And just before I finish up, in relation to the project, we saw it as an investment in our future. In a quote from Nelson Mandela, "Our children are our greatest treasure, they are our future." Thank you. There are some references available, and I would now like to hand over to Dr. Sarah Brown and Dr. Jennifer Shields. Thank you.
So I'm always very grateful to Jen for doing all our tweeting and all our IT and slides. So thanks, Jen, for being in control of the slides and moving them on for me. I'm very grateful to be able to come and speak to you as part of the Fetal Alcohol Advisory and Support Team, which is Scottish Government funded. And I'm going to tell you a bit about our journey over the last, I think it must be about 8 years now. So the hope for this session, we've got about 25 minutes. I'm going to speak for maybe the first 10, and then Jen will have the rest of the time. And really, we were the first group of people who have had some dedicated funding to develop some expertise in FASD. By the end of this, you'll hear a little bit about how that came about, a bit of what we've done with our time and the small amount of funding we've been given. We also sat on the Sign Guideline 156, which was published at the beginning of last year. And you'll hear a bit more from Jen about working with the families directly and what we hope to be doing in the coming years. So this is a confusing picture where I look like I've got an incredibly long head and straight hair, but I promise you it's still me. This was our other members of our team, and we had a full-time research assistant and support from public health who have been really helpful and supportive in Ayrshire. There's a map up on the top corner which just shows you about the geography of Scotland. So we're based kind of between Ayr and Irvine, and yeah, we got support from Edinburgh and the team over there. So this all goes back to 2012 when I had never met Jen, and there was some training put on by a Canadian team, which was that Professor Anna Hanlon-Dearman, her team, who'd come over from Winnipeg. Now, the Scottish Government paid for them to come over and do, I think it was 2 sets of 2 or 3 day training. They did one up in Highland and one in the Central Belt, which is what we call kind of Glasgow, Edinburgh. That was a result of one of the specialist advisors for the government scoping out practice around the world, and that was on a Churchill Fellowship. And when she met the Canadian team, saw the model they were using, which was back then the 4-digit code, she recommended they came back and trained Scottish clinicians. So Jen and I basically went away to this training in 2012, where we met alongside other speech and language colleagues and occupational therapists and some other clinical psychologists. And we took this learning back to Ayrshire. My role is as a lead for looked after and accommodated child health and a neurodevelopmental paediatrician. So FASD sits, right in between my areas of interest. And we knew we had children who needed this level of assessment. So we basically just kind of knitted together a bit of a virtual team and went on to diagnose 16 children. And then Jen and one of her colleagues audited how well we adhered to the Canadian model, which we'd been taught. And we found that we had very good fidelity to the model, which was the gold standard at the time. Jen, thank you. So we then put a bid together to the Scottish Government to see whether they would give some additional money just to free up some of our time so we could concentrate on developing a service, and they gave us 3 years worth of funding. I think it was going to be 2 years initially, and the plan in that 2 years was to trial a pathway, gain experience with FASD diagnosis, and we had great support both from the Canadian team who trained us, but also from Raja Mukherjee, who runs the clinic in Surrey, the national FASD clinic in Surrey. So as part of this, we developed awareness raising and training, and I think to date, along with colleagues, we have had awareness raising sessions for over 6,000 professionals in Scotland, and a lot of those will be in Ayrshire, but equally we have done roadshows to other health boards and helped supportive colleagues to raise awareness within their own patch. So this is just a very quick, this shows you what our team was made up of. Essentially it was myself for a day a week. I think Jen started off as 2 days a week and then 3 days a week. At some points we've had her 5 days a week. And I think the demand to have people who are dedicated and able to support other colleagues in this was really, really important. We had some time from occupational therapists, some time from speech and language therapists, and we've had good support from public health. Initially, we were going to see 24 cases, so 24 cases per year. When we opened for referrals, we found we were full within 4 months, and I think that just shows the demand out there for families who are living with young people who have FASD who may not be understood, and therefore supports can't be tailored adequately for them. So within 4 months, we basically filled our year 1 capacity, and then we had to reduce our year 2 capacity because after the diagnosis, we found that we had to then provide intervention and support because there was no other agencies to provide this because people didn't understand how to support the affected children that we were diagnosing. Jen and I are really rubbish at saying no to things, and therefore when we knew that our pilot was full and we knew there was such a big demand for these assessments, we basically set about upskilling our colleagues within the CAM service in Ayrshire and also within the other paediatricians with whom I work in a neurodevelopmental centre. So actually you ended up getting the same assessment whether you saw us or went to CAMS or community paediatrics, which from a research point of view, we kind of did ourselves out of our comparison group, which was unfortunate, but it was definitely the best thing for the families that we're meeting. So our key objective following this pilot was to make sure that everything that we learnt, we could disseminate. All the mistakes we made, we could tell people what they were. And I think we're pretty open that we have made mistakes and we have changed the way we've done things. And, you know, we've certainly learned from the families that we've met along the way and other professionals we've learned from along the way. But we have had probably input to over 200 assessments for children who may or may not have had an FASD diagnosis at the end of assessments. But we have worked in partnerships with families, we have developed resources in partnership with families, and we work closely with our third sector, which is the FASD Hub, which is supported by the Scottish Government and is a branch of Adoption UK Scotland, and they are funded to support not only adoptive parents but also kinship and birth parents. So then we weren't quite finished, so we felt that we wanted to explore what else we could do locally to improve intervention and support post-diagnosis. We also worked alongside colleagues on the Scottish Sign Guideline, and that's available online. We've also set up as a team over the last, I think it must be almost 2 years now, to be a point of contact for other Scottish health boards. If there's professionals who wish some support, we'll discuss cases with them, give guidance, and we also were part of running joint training with the Canadian team who came back last year, and we managed to get 14 or more than 14 teams, but a team from all Scottish health boards, which is multidisciplinary, and we trained them in the method of the SIGN guideline, which we'd also helped develop. So we are building, you know, a team here of people who should be becoming more confident in diagnosing FASD or assessing for FASD, but there's still, you know, going to be lots of training needs along the way. We've had input into some of the prevention work, particularly locally in Ayrshire, and as I say, public health has probably led on the prevention work here. But as a wider team, we've worked to develop a train-the-trainer programme to raise FASD awareness, and that was really to meet the demand for us attending training events. We've done summary guides of FASD, we've got our comprehensive resource, and we've got a parent carers guide and an educator's guide, both of which are available online. And as part of FASD Awareness Day today, we sent a pack to every CAMS team in each health board in Scotland, which shows our resources, but also it was things that OT recommended in terms of scaffolding learning and helping support young people, be it fidget toys, daily planners, a video voice recorder for aiding kind of working memory. And again, an example of that pack can be seen online. I think Jen has probably been tweeting pictures of it, so you can get a better look at it. SIGN Guideline is available online. It's based on the Canadian guideline, and that was published in 2016. So we basically, alongside SIGN, made it more applicable for the Scottish context. There is lots of other associated resources. There's a parent and carer guide that goes along with that, which is very useful. And yeah, you'll find a link to that online. And I think at this point, Jen is going to take over and speak to you a bit about what the assessment looks like and how we've supported families over the course of the projects.
Thanks, Sarah. I'm hoping everyone can hear me okay. Thanks very much to HSE and to Mary and colleagues for inviting us along today. And I'm just hoping to give a very quick overview. We've got limited time, so it's very much a whistle-stop tour. And I've just noted down some of the queries from the chat as well about the diagnostic process, and so I'll hopefully try and answer some of that as we go along. As you could see, we're quite a small team when we were doing our sort of specialist team approach, but essentially what we tried to do was to upskill a multidisciplinary team in each of our health board areas. So that would be including a clinical psychologist, occupational therapist, speech and language therapist, and a medical colleague, be it psychiatrist or pediatrician as well, so that they could undertake all those medical assessments and refer for genetics, MRI, where needed, and also to do the facial feature assessment and the head circumference. So that's covering the brain structure bit that you see in the sort of top left. And essentially from the multidisciplinary team perspective, we were looking to get evidence of 3 or more of the areas that you see on the diagram there being affected to a significant degree, and that's using standardised assessments where possible. So just to take you through the different assessments that we use, our occupational therapist would usually lead first in the assessment by looking at motor, fine motor, sensory issues, and looking at the profile of the child in respect to those. And quite a lot of the time we would see differences in sensory processing, and sometimes we would see differences in motor function, and sometimes these difficulties hadn't been previously discovered. In regards to communication, just very quickly, again, this was led by our speech and language therapist, usually doing a standardised assessment like the KELF. And we found that a lot of the children, and we've got data that we're publishing on this, had receptive, so comprehending what is being said was a difficulty, sometimes also being able to express themselves. But it was interesting, a lot of these children really did look like they could chat the chat and had a lot of content in speech. But really, when you got a professional to scratch the surface of that, we were seeing there was a lot of masking perhaps of ability, and really when you were sort of delving further, particularly the comprehension wasn't what you might expect from what was being presented. And these were some of the quotes that came from the parents and carers who fed into our service evaluation that you see online, and you can read that about the difficulties day to day. The cognitive assessment was undertaken by myself or my clinical psychology colleagues. Sometimes educational psychologists will have undertaken this. And where possible, we would choose an assessment based on the children's age and ability. And a lot of the children actually done not too badly on this, but not falling into that learning disability category. And clearly, if you were to stop at that, you would think, oh gosh, well, things are okay, it's a bit patchy, there's maybe some difficulties in working memory, but it is a screening assessment, so it's not definitive. And we do advocate for people to, again, delve further into the neuropsychology of the child, and I'll just take you through a few of the different other assessments that I would undertake. One of them is attention. We do screening assessments using questionnaire from parents and carers, but we did assess attention in a very boring room with a very boring, quite lengthy assessment to see how the child would sit and attend in that quite contrived environment. And you could see that a lot of the kids, had a strength in sustained attention, and that was despite many of them having been previously diagnosed with ADHD or not responding well to medication. A lot of the children had ceased medication because it hadn't been working for them. And what we were finding is that when school environment was adapted for the child and it wasn't too overstimulating for them, that their attention was improving in that environment also. And when they were in an environment that the brain wasn't being overloaded, sustained attention could be seen. So it does make the teasing apart of ADHD and FASD all the more difficult, but interesting and worthy to do. Memory, again, was undertaken by myself or psychology colleagues. We did a standardised assessment where possible, not always was it possible. It was very linked to communication. We often had to have a multidisciplinary discussion about what was a lack of ability to understand versus not being able to remember. Because if you can't understand and chunk the information, then it's difficult to file in that filing cabinet. This isn't to be confused with working memory, which is like if I gave you a telephone number and asked you to keep it in your mind, that sort of short-term active memory. This is more sort of long-term visual and verbal memory. And for some children, it wasn't a difficulty, but for some it really was, and was evidenced you know, to be even visual memory, and those are kids that were maybe asked to use visual means in school and it wasn't really working for them. So yeah, lots of times parents saying, you know, kids are just not remembering what I'm saying, and from day to day not retaining the information, and we were able to evidence that. And I should say on the back of that, normally my job was to evidence what parents and carers were saying, because, you know, they were coming in, the experts on their child, and I was basically providing the evidence for what they were describing. Executive function is really important. It's the sort of frontal lobes of the brain, the chief executive, if you like. It takes about half an hour to assess. There's a screening tool that parents and carers can also do. This is a bit of the brain that helps you sequence, organise, remember from learn from mistakes, remember what happened yesterday and what you're doing next week. It's the bit that really helps you with day-to-day function. And what we did find was that when we assessed for this, and this was a real area of difficulty, then the slide that you see here about adaptive and living skills was also a relative difficulty. They tended to correlate really strongly with each other, but not with cognition. And that's what's different from these kids to children with a learning disability. So the results of adaptive living skills is normally in the learning disability range. And again, as I repeat, not in keeping with their cognitive ability, but we suspect the executive functioning is what is impacting there. And so it's really important to get these measures of children. And also we ask teachers and class workers for reports about academic skills and take measures where possible as well as part of the assessment process. Very quickly to show the diagnostic algorithm that we use, if you have, for example, alcohol exposure confirmed and you have no sentinel facial features, which are measured by a pediatrician or psychiatrist, but you do have 3 or more areas where there's serious significant difficulties, then we would arrive at a diagnosis, FASD with sentinel facial features. We rule out the other explanatory reasons for a diagnosis. It's a diagnosis of exclusion. We do co-assess for ADHD and autism alongside because there are so many overlaps, but I do believe that you can differentiate as well, particularly if you have a good MDT way of working. We also take into consideration other substance use, but to be honest, looking at the evidence of heroin and cocaine use and whatnot, it's actually the alcohol that is the most significant teratogen of them all. And that's why, but we do take a full history of developmental exposures. The key learning about prevention we've already covered, and I'm sure I don't need to say again about the no alcohol, no risk, and the reasons why we need to have supportive conversations with people about prevention. But identification, we do know that, you know, neurodevelopmental issues and mental health issues, the overlap is the norm, and we need these children to be assessed within services that can recognise that. We need comprehensive risk histories, and what would help are better recording systems, particularly for care experienced children who have had prenatal exposures, and Sarah is doing some research and work on that. In Scotland, we recommended that services should be accepting of referrals where FASD is queried, that they should be assessed for under a neurodevelopmental pathway, not just specifically an FASD assessment and treatment centre. That wasn't going to work for us in Scotland because of the prevalence and the need. And assessment is complex, but you can do it. And the diagnosis can be co-created, the language around it can be considered holistically with the family, but the most important bit is that profile of strengths and difficulties and what that means for the child and the family. And the intervention coming from that is driven by a good understanding of that brain profile to provide the right support and the right training to the professionals and team around the child. We need to learn more about the impact of FASD in the context of Scotland, and just to show you evaluation to our team kind of launching into being a national resource. We also have, my slides are just struggling to keep up with my need to go really fast because I know I'm running out of time. The next slides, I'm just struggling to move it on. There we are. The next plan is to continue the commitments from the Scottish Government in our work thinking about raising awareness. We're still developing in Scotland, it's not all sorted. We need to still improve early identification, assessment, diagnosis. We've now got our third sector hub. that probably needs to expand as time goes on. And the government have also committed to, you know, more education and training provision and thinking about the recording. And part of the government's work has been to link with us and other experts in FASD around the creation of e-learning modules. We do face-to-face training, and we're also working on doing diagnostic training for people in the future. And we also run, or we're looking to work with partners to run an FASD forum where we can bring people together to continue their professional development. But the big question is, how are we going to implement this in Scotland? Well, we found out that there was a simultaneous piece of work regarding the mental health service provision for children. And Dame Denise Coya chaired that group and did an amazing piece of work. The late Dame Denise was a marvellous lady who achieved so much and put together this framework of recommendations for the task force, one of which was recognising the extent of neurodevelopmental difficulties in CAMHS and in community paediatrics, and the need for better ways of working for those children and families. We've linked with them, and so far we have a project initiation document, and the task force is committed to the design of a neurodevelopmental service. And these are services to be in every health board rolling out across Scotland, which will, as you see in the second point there, include the needs and assessments required by children affected by prenatal alcohol exposure. There will be no wrong door approach. This is all very aspirational. This is all in a project document saying this is what we hope to do. This isn't what we've done already, and we are working hard. But there is a particular note in the PID saying that there will be particular attention paid to children, young people in care and at risk of going into care, and to those who've been exposed to drugs and alcohol in utero. This schematic was done by a colleague in Greater Glasgow and Clyde, and I think captures our hopes for these children. And you see FASD there under that umbrella, but thinking about all the other things, all the other explanations and contributing factors. This is just a slide with our support and resources, and you can see how people can contact us. And we are really working hard now over the next 6 months. We've got funding to bridge with a university, Edinburgh University, and we will continue being members of these research groups and to think about all the data that we've collected so far about professionals' knowledge, the health economics. Parent and carer views is a current research study that we are committed to doing first, and then looking at neuropsychological profiles. And that's the end of the presentation. I hope I haven't went over time. Thank you so much for listening.
Hello, hi, Jen and Sarah. Thank you both very much. I have a fair number of questions that have come through, and I'm not sure if I'll just move on with them. I think what we have agreed is that Jennifer and Sarah will go into a little bit more detail on some of the questions that are being answered about, or being asked about their, you know, quite practically based and detailed presentations. And for about 10 minutes, so we'll have questions in relation to the Scottish experience. Thank you very much for your last slide about your keen to collaborate, because a lot of the questions and comments we were getting from the participants are very praiseworthy and laudatory about your efforts, and in Ireland we would look forward to linking with you, I think. One of the questions that is coming up quite a bit is the whole relationship between intellectual development, neurodevelopmental issues, and FASD, and in terms of specifically the interventions that are more helpful. I suppose more of the questions are about the treatment, but there are some about diagnosis, but maybe just in terms of the general interventions, where you might often have maybe not a rock solid diagnosis because they can be hard to get. So Sarah and Jennifer, I leave you interact on that.
Yeah, that's fine. I'm happy to comment on that, Joe. It's a really good question. So a lot of the time, the profile of the individual child was different, and what was interesting is a lot of the time, a major part of the intervention process was allowing people around the child to understand that profile in more in more detail. So in schools, really understanding at what level can a child understand, how many things can they keep in their head at the one time, what environmental differences do we need to put in place in the school and at home, what memory aids do we need to put in place, thinking about it, I suppose, along the lines of a brain injury and needing to either, well, it's difficult to rehabilitate brain injury, but in children there's lots of growth and plasticity to come. How can we really harness the strengths, and what can we do to help foster growth and development in the areas that are tricky? So asking our OTs about how we can help with fine motor development, gross motor development. Some of these areas people didn't even know needed extra focus, and we kind of call it like shining a light onto the areas, but also to help them to grow and develop. And for the things that are struggling to grow and develop, we've got aids and memory aids and visual planners that help children compensate for the things that they find difficult. But the key is understanding, and that's why we designed our booklets and pamphlets, which are available to everybody. You can go onto our website and just take them and download them. It's the understanding and the relief at being understood that was probably the most therapeutic bit for me. And I don't know, Sarah will add to that.
Yeah, I mean, I think, so I often meet the families right at the beginning, and I take a history, and, you know, we refer on to other colleagues, and my role's often the least time consuming. I come back in towards the end to think about the formulation and add in the medical components. But by and large, we're never telling families things they don't already know about their children. But what we do is put it in language that other agencies will recognise and understand. I also think one of the biggest therapeutic differences is often when people understand what level a child's functioning at, the expectations change, and that leads to the child being able to achieve more in people's eyes, because the expectation might not be what you're asking for their age, but what you're asking for is for their stage. And if they can manage that, then that gives them that chance to improve their self-esteem. It can kind of diffuse sometimes some of the tensions within the house. If you think you've got a 12-year-old who should be doing things like other 12-year-olds, but if you think about them like an 8-year-old and need to support them in how to plan for their school day, etc., that can really, really help. And that doesn't require a diagnosis. It just, I suppose Jen always uses the word lens. It just requires people to see children in a slightly different way, under a slightly different lens. The one thing that I think we're always surprised at, and usually we can predict, or families tell us what their children really struggle with. One thing that I think has been really key, and that Jen and I have learned over the years, is the impact that having a really good quality speech and language therapy assessment can make. Because often children and young people appear that they're age appropriate with their language, you know, but actually when you really drill down, you can find that they're really quite lost when you're using complex language. I think children who are feeling lost or who are struggling to achieve what other people expect of them can often act out in different ways and demonstrate their, you know, frustration, and that can be quite misinterpreted both by families and supporting agencies.
Can I just ask another question? People are just looking for practical advice about breastfeeding. There has been a few questions about that.
So I can answer that one. I think, you know, the advice regarding breastfeeding is that you should be avoiding alcohol when you're breastfeeding. The science behind that is one thing. I think the other thing, though, is if you're drinking alcohol and feeding, where is I suppose there's a risk about how competent you are to care for an infant. Are you going to be sleeping more deeply? If the infant falls asleep next to you whilst you're feeding? So there's other risks associated without even, you know, simply just thinking about the alcohol that being the breast milk and being passed to the child. So I think it's kind of a wider question.
And the other thing, are your service in Ayrshire and Ireland, is that a sort of leading across Scotland? Are you sort of training the rest of the country as well? I was trying to figure that out, and because access to good, and that is quite. And then we can open it up then after this question maybe to the sixth panel, because we have some other questions that are linked. Just the structure of how, and I know you're obviously getting money in different sources.
So So I'll let Jen answer this one, as long as she doesn't promise to come and train everybody in Europe whilst we're still there.
Yeah, so there is, as I said, there's a long way to go, but the hope is that our team can help to scaffold and support others to be more confident in FASD, and it's almost like a cascade model of knowledge and then confidence. What we've learned is that you can't just supply people with a guideline, like, you know, the SIGHT guideline, and say, can you do this? People need to have experiential training, and we've now partnered with the Canadian colleagues to learn how to do that, and we've co-run sessions with them. And so we're hoping to do sort of diagnostic training, but to be honest, we're needing to bridge with the university and build an infrastructure to allow us to think about how we would go about doing that and get a training strategy. So all of that has been managed by the Scottish Government so far, and I think about 400 clinicians have been trained through the Scottish Government, arranging diagnosis training for clinicians from across the country. And we are just maybe hoping to build on that in time. But it's a huge job and it'll take time, and we are still, you know, in the early stages of growth there.
Okay, I think what we will do now is we will invite Mary and Geraldine and Caroline and Noelle to join us as well. So we'll open up. We have about a half an hour left, and what I want to do firstly is ask Caroline to say a little bit. Caroline works with TUSLA, which is our child and family service. Or there's quite a lot of talk about the integration between children's services and children in care. Any impressions, I suppose, because this is holistic care, as we're trying to achieve in Ireland. So I don't know, Caroline, if you have anything you'd like to sort of contribute just at this stage.
Yes, yeah, I mean, TUSLA, as you know, has early intervention, prevention, family support, but also we have such a big range of children in care. We've over 6,000 children in care. Most of them are fostered, and there is and has been for years now, I suppose, a frustration in trying to assist these children through accessing CAM services, through HSE services, through actually trying to privately fund therapeutic services. So this model that you are, I suppose, promoting and have talked to us is such a promise, I suppose, of hope for the future. Okay, and we're very much, I suppose, on track in terms of working with the HSE around hidden harm, in particular the adult addiction services and the community and voluntary sector and our TUSLA services have access to joint e-learning on hidden harm. And fetal alcohol syndrome and fetal alcohol spectrum disorders are part of that, understanding the perinatal, antenatal part of it. One of our questions, I suppose, is really how can we incorporate, I suppose, a wider range of practitioners, including our CAMs, in having a community around practice on this, because there's very much an interconnection. And we don't have that easy at the moment, really. It took a number of years to get the hidden harm e-learning up and running for HSE and TUSLA. So it'd be really important, I suppose, to highlight, we'd like to understand maybe how we can get that integrated approach planning at this stage. Thank you.
Okay, well, we'll come back to practice again in thank you, Caroline. And just Noelle, in relation to, from your perspective, are there any comments you'd like to make, I suppose, on the Scottish experience, but equally the other presentations, and then we'll move on to questions that will be answered by several panel members, I would imagine. So, Noelle, if you're there.
Sorry, difficulty with the mute button. I guess we're excited by all the Scottish team have achieved, and we look forward to further development in Ireland, because it's been very difficult not having access to services or access to diagnosis for a lot of families. Just to mention, I'm representing the group NPAE at the moment. We are an all-Ireland support group.
Do you want to just say a little bit about it? Yeah, okay.
Yep.
Okay.
So we have
Okay.
experience from families that are made up of biological, adoptive, foster families, all variations, caring for people with FASD. So we're seeing the front line, or we're on the ground with people who are actually living it. And we would like to see progress in that area too.
Okay, thank you. Now I have a few other questions, and many of them are linked. So one is to do with the practice in maternity hospitals. There's been a few questions about this. Why isn't this issue addressed in more detail? Now I know, Geraldine, maybe you can talk about the challenges, because we were trying to get not quite screening, but get even questions asked about alcohol in pregnancy higher on the agenda. And maybe Mary, from your role on the expert advisory group, you might say what the aspirations are there, and there are other questions about the expert advisory group that you might like to answer in terms of the guy, what the aim is, what the timescale. And for Geraldine, then, what were the real challenges with your peers in trying to get this issue higher up the agenda in Letterkenny? And there have also been questions about where people can get access to your evaluation report. So maybe we start with Mary and Geraldine on the issue of the antenatal care and how that can be better delivered with FASD in mind.
Thank you, Joe. Well, as you say, we've been trying to get more information on alcohol in pregnancy collected during pregnancy. And one of my colleagues, Dr. Siobhan Jennings, who's now retired, but she drew up a minimum data set for the whole Healthy Ireland for our key priority areas. And that has been included in the electronic maternity record. So at least now on the electronic maternity record, we have it primed to prompt people to ask the questions about alcohol, and and to prompt what action should happen depending on the answers that they get. As you know, the electronic record, I suppose, to date, it is only rolled out in 4 hospitals in the country, and we have 19 maternity hospitals. So that's kind of a slow burn and a slow process. We are still at a situation trying to get general acceptance of the message, with all our nursing and medical colleagues, that no amount of alcohol at any stage of pregnancy is safe for your baby. And that's, I suppose, one of the first things that we'd be hoping the FASD expert advisory group would do, is that we would develop a statement for the HSE on pregnancy and alcohol, and then that we would take that forward and hope to get joint positions with the constituent colleges like the Institute of Obstetrics and Gynecologists, Faculty of Public Health, and through the Royal College of Physicians of Ireland.
Okay, and there was a few questions, Mary, just about is the membership and the aims of the terms of reference of the expert advisory group, is that public? Is that accessible, like?
Joe, Mary's just gone for a moment, if you want to go to Geraldine.
Okay. Geraldine, hi. Just in relation to your presentation and, the getting the buy-in and all that, would you just give us an idea of what were the, mainly just, I suppose, because the idea would be to try and replicate, I presume, what you're doing in other parts of the country, and what would you see will be the challenges and how might they be, overcome?
For us, I suppose time was a challenge, during the process, but we overcame that. As for the follow-on process, I suppose there was a mix of work schedules in the different agencies and lack of resources. But I would have to say that we have continued with a very comprehensive alcohol assessment for every pregnant woman coming to book at the antenatal clinic. Whilst we don't have the national electronic system, we have a different electronic system which incorporates a very comprehensive assessment for alcohol. This will be accentuated now with the rollout of MEC, which is going to put more emphasis on that as well. So we are still actively assessing ladies and acting on the results that we find.
Okay. I have a couple of questions Caroline, there was just two questions. One about whether a legal guardian can get a social worker, and the other is whether training will be provided for. Oh, the questions. Whether training is being provided, within TUSLA for relevant staff about FASD specifically.
What I would say is that currently we don't have specific training on fetal alcohol spectrum disorders. It's the hidden harm e-learning that we have, which is accessible for all staff, and there will be classroom training. I do know that a lot of our teams, our social work teams and our foster parents, but we do not have a bespoke training available.
Right. Okay. There's another question about other psychoactive substances, whether they can impact on the development of the fetus's brain, and that's benzodiazepines and methadone and things like that. Because obviously, some people take alcohol only, some people take alcohol with other stuff. So for anybody want to? From any Jennifer or Sarah or Mary?
Sarah and I could.
I suppose what the question is about is people who are, say, using other substances apart from alcohol.
Yeah, the most recent evidence that we've been presented, and I suppose this goes along with what else is in the literature, is that alcohol, because of the ethanol molecule, and it freely passes across cells and the placenta, it has probably more teratogenic, and it has more teratogenic effects than heroin, cocaine, other sort of drugs that you might hear about. The evidence that we heard in Vancouver, Canada, that there was a conference, and the synergistic effect between synthetic cannabis and alcohol, their thinking can be worse than alcohol alone. But certainly that's why we usually are quite confident about our differentials when we've got a strong alcohol history, and that is something we do look for in all of our assessments. And we do look in terms of the number of binges, if you like, during pregnancy to be, it depends on how much is ingested within a binge, but 3 or more would be something that we would be thinking about. And I think your confidence level of attributing FASD goes up with the more binges, and it tends to be our alcohol histories are quite strong, and very rarely there may be 1 or 2 or 3, but you just never know because of the genetic makeup of the mum, the placenta, the fetus, the nutritional elements. There's lots of complicating factors, but that's what we would say about the drugs, because people do sometimes think heroin is worse, and it isn't.
Thank you.
I don't know if anyone would want to add to that.
I suppose I would just add that I think we're seeing a shift in recording, certainly within Ayrshire, and with greater awareness about the importance of recording alcohol histories and our local training. We often get it included now in referral letters. So what I would like is for every child who gets referred into a child development centre to have, as medics and people who refer in, we're very used to saying, such and such was born at 37 weeks gestation, weighing 4 kilos. And it's part of the narrative that we say they were born by C-section or normal delivery. And actually that matters far less than whether the pregnancy was recognised at 4 weeks, 5 weeks, 6 weeks, whether it was a concealed pregnancy, whether lifestyle changed. That's the kind of information that we need to get people to be thinking about and getting people to capture. Because if we're not changing that out there in our support services, be it health, for people who are more vulnerable, if they're involved with other support services, it's capturing that information and making sure that it's well documented and well recorded. Because with the best facial features and there is no substantial alcohol history that I can locate, even if I think that it was very likely to be FASD, you can't make that diagnosis. You need to have either the facial features or a solid alcohol history. Equally, the diagnosis in itself is not the be all and end all. It's actually the understanding that goes with a good neurodevelopmental profile. So if you're struggling to get an alcohol history and you're struggling to get, and if you don't have facial features, it's about having that really good, well-rounded understanding about a child's profile, and that should still be able to help you understand that child and help them access the supports they need.
Okay, thank you. There are a range of questions and comments that are essentially asking, can we be a bit more like Scotland in how we resource and deal with this issue? Because we do get a lot of support from Scotland on alcohol issues generally in public health in Ireland. And also we have a very similar demographic and behavioral cultural links. And the question is whether, how can, and this I suppose is a question for, I mean, Mary is involved with the EAG. How can we make assessment more robust? How can we make, have multidisciplinary teams, have hubs, where people are dedicated, where their role is to try and help children and their families to deal with what something is not that easy to diagnose, as Sarah says, but that's not the issue. I mean, to make child services better in the context of FASD, what sort of structures? I don't know whether there's anybody has any information about a grant plan. I know that the HSE would like to have and is hoping to have better assessment systems and that, but how can that, and better diagnostic clinics and stuff like that, how can we make that more likely to happen, and what's the practical way we can get support from our colleagues in Scotland? So that's a question for everybody. Anybody wants to step in with that, but that's coming up quite a lot.
I suppose it's well recognised that we are lacking supports for, services for diagnosis and for intervention with FASD in Ireland. And I suppose I'm not clear, Joe, as to how we can go about building it really, in that it will require leadership really from child and adolescent mental health and from paediatrics. But we do have those represented on the expert advisory group. And I think this survey that we are planning, will hopefully identify how maybe we can try to go forward or what the extent of the need is, so that we can put the business plan together as well for the HSE.
Okay. Can I ask Sarah and Jennifer, you mentioned at the end, I think it was yourself, Jennifer, at the end of your presentation that you would like to collaborate. Would you like to give something? How could you see that happening? Because I think it would be very helpful to us to be able to maintain some relationship with what you're doing.
I'm just watching Sarah anxiously looking at what I'm about to say. I just think that
really hard when we're not in the same room, you see.
I think in the world of FASD, I mean, we are really aware of standing on the shoulders of giants. People have done so much work for decades to get us to where we are just now. And people like Rajan Mukherjee in the UK, Sandra Butcher, NoFAS, many others that know who they are, we are indebted to them, and we've gotten so much help. And I think that's why our website is open to people to use our resources, and we are making a sort of UK network of people interested in FASD and research. There might be scope to think about international connections, thinking about connections between countries, how we share learning in a sort of efficient way that, might not entail us going away for too long, Sarah. But with our government's permission, I think we are keen to share our learning and not have everybody reinventing the wheel is essentially the nub of it. And that's as well why we want to get our research and evidence base out there, because our countries are very similar.
And I think we're very open to wanting to connect with other clinicians and help other people move services forward. I suppose I've always bad cop to Jen's, enthusiastic kind of personality, simply because we are both part-time at this. We could do this day in, day out, 52 weeks of the year. And the reality is that we need to link with like-minded people who need support but are able to drive things on in their own kind of patch. Even within Scotland, we don't see children from out with Ayrshire. We're not a national service. We were a service that was started up within a health board to gain a bit of expertise, and then we can consult and support other clinicians and professionals. We have had a bit of an extension in our funding, which is good, and I would hope that we will build on that, year on year. I think there is a huge need for good quality, recurring diagnostic training and ongoing support, and that's not just within Scotland. It should be able to be available to. It's not really about the clinicians; it's about the families that need to be able to access people who are able to help them move forward with their family life, and make sure they have happy young people and successful adults. And I suppose part of what drives us is wanting that for as many people as we can, but there's got to be a little bit of realism that we do struggle to meet the demand for training. I am not as probably good at Jen on terms of kind of webinars and social media and all the rest of it, and there's huge limitations from kind of just those softer skills and doing things on web-based platforms. But what it does mean is we can do training that's an hour and a half long without having to get on a plane and fly to a different country and stay in a hotel, and do it. So in some ways our time we can be a wee bit more generous with some of our time. And I think that that's probably one of the benefits of COVID, is that we're able to connect in a way in a platform that nobody would have envisaged this being possible probably a year ago. So I think that there are new ways of working and collaborating, and we'd certainly be open to that. I think we probably need to get ourselves into a place where we've got a dedicated training resource that we can, use and try and use that as a support for other interested professionals.
Okay, I've about the questions are still coming in. We're still almost 400 per. So there's a few quick ones that are there, and I'd start. One is for Tusla as to whether there is any thought being given to having some type of a screening or assessment tool to make some adjudication when a child comes into care, because that's come up. That is one. A second one is advice about talking to parents about the implications. I mean, that's fairly general, but it's sort of fairly practical. And is there any link with the school system in terms of, because the schools are areas where issues can come to light for the first time ever, whether there's any, and I know some of these questions can't be answered, but we can maybe follow up in the seminar, whether there's any link with the schools in terms of being a support when this is becoming an issue. So just first of all about children coming into care, because it's, I suppose it does, leaving the resource issues aside for the moment, but there are lots of gaps in the health end of child services for sure. And there's disputes between who's responsible for mental health services. And these are as old as I've been in the health service. But if we really want to try and support children, I think this issue needs to be taken more seriously by all of us.
Absolutely, no, I would agree. And I suppose one of the biggest things for us is when we do make care plans for children, we need the expertise of health. We need the expertise. We do know that children are with adversities, OC in partnership, and resources to be prioritized for this very high need group. So I would say yes, and I would say yes to having really good training for our foster carers, for our social workers, but it has to be expert-led and evidence-informed, and it has to have proper care pathways, proper assessments and interventions, really. The diagnosis piece, I think, has been eye-opening in terms of you have to have that multidisciplinary team, and it has to be resourced to work together. and it has to have that specialist function in order to prioritize those children. So all of the things that have been raised by the panel and by the questions that have been raised, I would say, are highlighting the gaps that have been there. I think what we have positively working for us at the moment is that we have expertise to draw on, but we have good working relationships that we need to actually come together much more, I suppose, focused in terms of this work and to drive it onwards. And TUSA will be very much behind that, because we have to advocate and we are promoting children's well-being and their life, their futures. The futures of these children is so important that we get it right as early as possible. In terms of parents who may be referred into TUSA, just to say, under our Children First guidance, there is a lot of support, I suppose, for referrers in terms of if they have reasonable concerns or grounds for concern, they should approach our social services and have the conversation about how supports might be needed, or if there needs to be a social work assessment in terms of child protection and welfare.
Okay.
Okay.
Thanks,
I
Caroline.
just say, I'm not sure if this fits in here, but I just thought I should say that the best learning that I have done has been from the parents and carers using the service that we piloted. And I think it's so crucial that we really, especially when we think about all the type of families that will be involved in these services, that we are led by them in the development of training and services. And I don't know if anyone wants to comment on that, but I just wanted to make that really clear that from Scotland's learning, that's been our key message.
Absolutely.
Okay. There are a few questions from people who are looking for immediate help, and I don't know how I don't think we can signposting people to services. So could somebody, is there a directory of services within the HSE as to where people might go who have difficulties with their children? I'm not quite sure what's happening. Is it FASD? Well, a few questions have come up in that area. So maybe I know that this webinar has been recorded, and I think the plan is to put the contents up on the YouTube channel of Health and Wellbeing. But obviously, seminars with 500 people will bring up lots of issues that need to be addressed after the webinar where possible. So we just need to think of that within the HSE as to how we can signpost people as to where they may get some help.
Can I briefly address that, Joe?
Pardon?
Can I
sure,
take a shot at that for a minute? Thanks.
Yeah.
Our website is available. We have a Facebook group, which is becoming more active. We're not that long in operation, just a couple of years at this point. But we also have very active online and in-person support groups about every month. We also can respond to Facebook messaging and private messages, phone calls. We will meet up for a cuppa with someone if they need a chat, if we're in a local area, we're spread out throughout the country. We're trying to currently set up local hubs as well as the national meetings that we do have frequently. We were using Zoom for the last couple of years before it became so popular. And we have practical resources and downloadable stuff on our website, which can just give parents and carers somewhere to start, actions they can take today that will help in managing their child usually, but also any other affected person with FASD. And we can give some guidance on professionals to approach, particular assessments to request when you are offered some services or assessments. And it's more helpful. And we also help them work with schools, because a lot of the issues arise in school and cause a lot of difficulty there.
Okay, Noel, that's very helpful. We will work out the logistics, but I mean, there is going to be, as I said, the proceedings will go up, and there have already been some websites and presentations. So other information, I think it would be useful, because there's been there's been a lot of questions, all different types of questions. We tried to just cover some of them, and as many as we could, because there was a lot of overlap.
Joe, just to say that we have a full report of the questions that were unanswered, so
Right.
we can endeavour to answer them post-webinar
Great.
and get them out to the attendees.
That's terrific, Leo. Yeah.
Might I just launch a poll before you wrap up, Joe? Might I just launch our final poll there? There's been a lot of information there, so we just want to gauge the audience, please. So, did you learn something new about FASD through your participation in this webinar? So if you could vote there, folks, before Joe wraps up for today. Thank you very much. That's great, Joe. If you want to wrap up, I'll share the results there.
Okay. Oh, I mean, the wrap up is really thank yous, I think, and just where we're going now. So firstly, in thank you, I'd like to thank Leo Colgan and Shane Hartigan from IMS. They have steered us through, us that have been involved in putting this together, have steered us through very well over the last few days to get things as good as we could do. And I hope the experience was fairly good for people. So thank you to Leo and Shane, firstly. And then to the organizing group. I really had nothing to do with it. I was asked to chair it. And specifically the presenters, Mary O'Mahony, Geraldine Hanley, Jennifer Shields and Sarah Brown from Scotland, and Noel Yudkin and Caroline from Tusla. Thank you all very much for your presentations and your inputs, and thank you all participants. There's 313 of you left, but there was up to 500 at one stage. So as I said, the proceedings have been recorded, and there will be some follow-up for sure. You will answering specific questions because basically we all always have to demonstrate an unmet need before things really move along in this country. So this has been quite an important event in the story of FASD within Ireland to try and get something moving and really, provide a proper service for people who require it. And Caroline Jordan from Tusla as well. So thank you all. And I don't think there's anything else left to be said. Just initially as well, who weren't on screen today, Fergal Fox and Marion Rackard, who did quite a bit of work behind the scenes to make this event happen. These things don't happen by chance, and they've been in preparation for months. And again, this was a special thank you to our two Scottish colleagues. I always find working with Scottish people is really terrific and a great experience, and it's the same today. So thank you all.
Thank you.
Thank you, Joe. Thanks, Sarah and Jennifer.
Thanks, Noah and Geraldine. Thanks very much.